All right. Well, we'll go ahead and get started with today's AMSSM Sports Ultrasound case series presentation. I have the pleasure of introducing Dr. Stephen Henry. He's faculty in the Department of Orthopedics and Family Medicine at the University of Miami and adjunct faculty in the Department of Kinesiology and Sports Sciences. He teaches primary care sports medicine fellowship as well as within the athletic training program and does serve as the team physician for the Miami Hurricanes and the Miami Marlins. He's very passionate about helping athletes and active patients thrive. And outside of medicine, he enjoys weight training, Brazilian Jiu Jitsu, biking, and running. And today he's going to be giving us a case presentation on internal snapping hip syndrome.
Yeah, thank you. I appreciate the opportunity to speak to you about this case I had of internal snapping hip syndrome. This is really a protocol ultrasound. We're focusing on that anterior hip. The goal is to obviously give you a little bit of background about snapping hip. I'll talk to you about my case, which is interesting. This is when I first saw my patient, we were just thinking it's a rudimentary degenerative changes in the hip case, but we'll talk more about that later. We'll speak about a protocol-based approach that's more so anteriorly focused. We'll talk about the dynamic mechanism of how we diagnose internal snapping hip and then syndrome, and then we'll segue into case ultrasound findings and some teaching pearls or points. So obviously here we have the anatomy. Knowing where the anatomy is, the origin and insertion is critical, and our primary focus is going to be really in this region where our psoas major and our iliacus is, as well as our sartorius, rectus femoris, etc. So all this should be, kind of a review for everyone here. And so when you think about snapping hip syndrome, really trying to understand, the intra-articular causes as well as the extra-articular causes, so we organize our thought process that way. Talk about the role of that in this case, and then understanding the relationship really between that psoas tendon and the medial fibers of the iliacus snapping against the superior pubic rami versus an iliotibial band snapping over the Gmax. And of course, everyone's familiar with snapping hip on some level. There's been numerous lectures before on this topic, but I think there was a nuance here to this case that I want to elucidate. We commonly see snapping hip in ballet dancers 90% of the time, or folks in that realm. You really see it in 5 to 10% of the patient population. But in my case, I had a 55-year-old female who, she came to the clinic with worsening hip pain, specifically that right hip, after doing some weighted glute bridge exercises. So she noted that she felt some pain. She had a snapping sensation during the workout. But like most CrossFit athletes and folks that are, avid workout, people, she pushed through, and she then segued to kettlebell squats, and then she felt a snap and pain again. She described it kind of a 6 out of 10 in nature. That's dull and achy. And a critical point here in the presentation is where she denies any numbness and tingling. So just from that history, I was really thinking, okay, this is likely hip focused, of course, but the numbness and tingling component, let me think less about a lumbar component to her pain, something like a lumbar radiculopathy. Her medical history was positive for, Paget's disease and osteopenia. And when I had examined her, of course, looking at her hip, it looked normal. When someone comes in with hip pain or, said that they felt a snap, you want to look for any sort of obvious deformity. We're thinking, is this some sort of muscular rupture? Is there ecchymosis in the area? Is this an avulsion picture? But that wasn't the case. So she had the pertinent negative of no ecchymosis, no bruising. And I proceeded to palpate her anterior hip between that ASIS and AIS region. And she started to say, hey, I'm a little tender there. Segue into range of motion testing with some hip flexion, abduction, external rotation. And once I moved that hip into that position, she felt that snap, and I was able to reproduce it again and segued her to an external adducted, internal rotated position. And then did it again, and she felt the snap. So, I did some special tests. Logrel was positive, Fabers was positive, Federa was positive. She had a positive Thomas test. So right away, everything is kind of honing in on that iliopsoas musculature. So of course, we have to think broad. So I did an X-ray. This is your AP view here. Everything looked normal. My radiologist looked at it as well. We're done view here, and aside from a little bit of osteopenia through, joint space look largely maintained. The interesting thing is that, like most of our patients, this patient came armed with an MRI. And so we had a dialogue there where she said, hey, my x-rays are normal, but no, I have this MRI and it shows that I have this chondral defect, over that femoral head, and she had some osteophytes. And so, we were going back and forth about, what would be the driver of her pain? Is it, some cartilage degeneration that we're picking up in MRI versus the snapping sensation? I think that made the case unique. And so we have to start asking ourselves, what is this true pain generator? Is it, which structure is a pain generator for that? Is it the, the iliopsoas, or is it the degenerative changes? So with that information, I'm sitting there in clinic, we have an MRI, we have an X-ray, and so that's where the use of the ultrasound comes in, right? And so having an organized way to approach, the scan is important. So I I graduated in 17, so I've been doing this now maybe about 7 years. And so I always found it useful to have a systematic approach. So what I do is, I focus on the anterior hip, make sure I can visualize that femoral head, neck, capsule, anterior synovial recess, make sure that I look for any evidence of joint effusion. And it's important that at this particular stage, when you're looking for joint effusion, you understand that you're dealing with a double layered capsule, right? We see that in the literature all the time, and I'll mention that again in some follow-up slides. But that becomes important, especially from a dynamic standpoint, because oftentimes you can move that patient into flexion, abduction, external rotation, and you may even see some distension of that joint capsule, which you shouldn't mistake for pathology. It's just really a distension of the capsule, and I have a couple of videos to show later. But as you put your probe, in that sagittal oblique plane, you're able to see the femur. You're able to visualize portions of the acetabulum. You next can move a little bit medially and can know medial and superior, and you can take a look at the femoral vessels and nerves. You can visualize the iliopsoas, tendon, and bursa. And from there, you can put your probe on that ASIS and start to see fibers of your sartorius, move laterally, see your TFL. And then you can move down to your AIS, see your rectus femoris, and look at, both the indirect and direct fibers of that. And so once you kind of have that protocol-based approach, it makes things organized. And so you're not all over the place with your scan. And so scan probe choice is really linear. If you want to really get some nice pictures superficially, this image is more of a linear view using a linear probe rather. And then curvilinear allows that depth. The trade-off there is you may lose, some clarity in the image, but that depth allows you to, take advantage of if a patient has a large body habitus. Just to be complete, I've included the protocols for a medial hip exam. The reason why I thought this would be useful, so if we were to flip my case scenario in its head and the patient did have some numbness and tingling, one thing to think about is an obturator nerve entrapment. And so being able to identify, the obturator nerve as we move medially, if you take your probe, move towards that pubic rami, we see fibers of the pectineus, we see the fibers of adductor longus, brevis, and magnus, and gracilis, and the obturator nerve lives in there. And so being able to tease that out and have a dynamic component to the medial scan is important. And then, of course, this is one of my favorite views, a lateral hip exam. I think as a fellow, this was one of the first things I was able to identify and got motivated about this. So you're able to see your facets here, your anterior lateral facets. Your probe is a linear probe on that lateral aspect of the hip at the greater trochanteric area. And then you can see the details on an MRI comparison. So again, just a systematic approach to this is important. This becomes important a little bit later on if you think the patient has more of an external component, to their snapping hip, and we'll talk about that a little bit later. And then last but not least, the posterior hip scan, right? Sometimes you can have quadratus femoris impingement. You may have a sciatic nerve entrapment. You may even deal with a concomitant, proximal hamstring strain along with the patient presenting with hip pain. So being familiar with this approach and having a protocol for that is important. Here we see your probe along the distribution of the piriformis, and oftentimes you can see if there's like a piriformis contribution to the patient's pain. So becoming familiar with that scanning protocol is important. So refocusing back to that anterior hip is about 4 to 6 millimeters thick. We mentioned that that joint capsule extends inferiorly from that labrum, which is here, and then inserts on the intertrochanteric line. But some of these fibers end up being reflected, and each fiber is about 2 or 3 millimeters thick. And you'll have some physiologic fluid between that area. You see your rectus femoris here. So being able to identify that's important. But I bring this conversation up because one of the first things you can pick up is if the patient has a joint effusion, you can capture that on your report right away. And if you recall, the MRI did mention that there were some degenerative changes in my patient. So I was curious to see if there was any joint effusion. Of course, she didn't have any, but you're able to, again, identify that by appreciating that each capsule, that it kind of reflects on itself. It's echogenic and fibrillar in nature. Again, we see that picture I showed you earlier, and then knowing that that femoral, neck should be smooth. If it had cortical irregularities, or if you saw, obviously, the capsular distension, that would point to more of an active degenerative pathology, that kind of process. And then being able to know where your labrum is, right? All we have to do is just move a little bit more medially. We could see this is a normal labrum, but if you had a tear or you were, had a high index of suspicion for that, perhaps you may see some sort of, anechoic area here, or a small cleft, or perhaps even a paralabral cyst, which you can capture if that's a contributor to your pain during a dynamic exam. So what we're seeing here is the utility of the ultrasound being able to give us that information right away, and we can compare it to that MRI. And I spoke to you a little bit about this concept of capsular distension versus joint effusion. I think it's important because here what we're doing is on this video, you're seeing that we're flexing that patient and then applying some internal rotation. And we're seeing that distension of the fluid capsule, which is not pathologic. This is just normal, distension at a bulging surface of the capsule, which is important to distinguish from what a true joint effusion is. So, I have some notes here about capsular distension. We can clearly see that this capsule is enlarged compared to the pictures I show. And there's some talk in the literature about, measurements of the capsule. But I think if you have a case like this, what I like to do is I'll look at the unaffected hip and use that as an internal control. This is a pediatric patient that I took a picture of. And so you can kind of, have your index of suspicion high for associated growth plate injuries or an avulsion fractures in this area. So you will, see some cortical irregularities there. This is a scan of an adult patient showing distension of that joint capsule, both in long axis and short axis. So, back to the star of the show, we have the iliopsoas region. This is just a phenomenal paper. Previous lecturers have spoken about this paper and the impact it has had on us understanding the anatomic relationship of the iliopsoas complex. But you really want to start with your probe over the, putting your transducer over that area of the femoral neck. You can easily identify that. And for me, I actually like to start at the SIS, identify the sartorius, and then, move slightly inferior down to this region B, so I can see now the relationship of that psoas major tendon, identify the neurovascular structures. And typically I like to drop that color Doppler on so I can clearly see that artery pulsating. And this is the AIS. This area is the psoas tendon, obviously, and the fibers of the iliacus. So red is your psoas tendon. Yellow here, we see the medial fibers of the iliacus. Purple, we see the lateral fibers of the iliacus. And of course, blue, we'll see that infratrochanteric muscle that's highlighted here. The black star is your iliopubic eminence. And so you want to be comfortable with moving your probe between the ASIS and the AIS so you can really capture the breadth of that psoas and, examine it dynamically. This is an extended field view from the same paper. The authors mentioned that this is an important concept just to extend the field of view and be able to look at that relationship between the psoas major tendon, medial fibers of the iliacus, and obviously the relationship to the suprapubic rami. So very cool picture there. So to be thorough, what we did is we identified, and of course, as I mentioned, I like to start at the SIS. Here we see our sartorius in long axis. You can move your probe and move it in a short axis view and, see the tensor fasciae lata, and see the rectus, iliopsoas, and the sartorius. If you're, skilled enough, you can also capture fibers of that lateral femoral cutaneous nerve. And here, again, just understanding the anatomy and where things are is important. Again, this becomes important in your pediatric population. Perhaps you can capture, cortical irregularities at this ASIS. You can capture hip flexion injuries. So it's very important. So again, let's delve into the rectus femoris, right? So the rectus femoris, we bring our probe down to, linear fashion down to the AIS, and we see the fibers of the direct tendon of the rectus femoris. I have a video here that shows the direct tendon, but then we draw our eyes to this area where we see this hypoechoic region, which is really the indirect tendon. It's that characteristic shadowing because of the angle that the indirect tendon takes. And this picture is a nice picture because it shows you that the indirect tendon, reflects and merges to the super acetabular rim. We see the fibers of the indirect tendon and its relationship to the direct tendon of the rectus femoris. So I think it's very important to understand that relationship. And then oftentimes, if you want to visualize that indirect tendon, you may want to bring your probe a little bit laterally. As you're looking at that direct tendon of the rectus femoris, you can change your probe in a short axis view. You're simply just moving your probe from long axis to short axis and appreciate the iliopsoas, the sartorius, and then, the bright hyper echogenicity noted here in that rectus femoris. This is the indirect head. I like this picture because it's a cadaveric specimen showing the anatomy and showing the relationship between the rectus femoris and the iliopsoas. You can tell is if you can get to that coronal oblique plane over the lateral acetabulum, you can really get a nice picture of that indirect head of the rectus femoris, and it becomes important in a patient like this who presents with hip pain. And this is just another picture of that. And so bringing it back to my case, I mentioned that, a lot of the snapping hip conditions happens in dancers. My case was unique in the sense that this is a CrossFit athlete. Her, she's 55 years old. Typically, you'll see it in the younger patient population. But then the classification scheme becomes important, right? Understanding that you have that intra-articular cause, which is loose bodies, labral tears, that could be a source of a snap versus an extra-articular cause, which, in itself could be lateral, which we see here, that iliotibial band and that Gmax snapping over the GTB in this picture, versus that medial relationship. And I'll add a level of detail here because, when you examine the literature early on, you'll see this conversation about, is it the fibers of the psoas tendon being trapped over the iliopectineal eminence versus being trapped in the medial fibers when you do your Faber's physical exam during dynamic scanning. So I think, more so in the literature, we're leaning towards, medial fibers of the iliacus trapping that psoas tendon, and we're shifting away from the old dogma of the iliopectineal eminence serving a role in this snapping sensation. And so back to my patient, you can see here in this image on the left, we see that tendon snapping into the suprapubic rami as I flex abduct and externally rotate. I'll click that again for you here. And here's another view of that. And I juxtaposed the image from that paper. I mentioned that for me, it really does a nice job with, expanding on the anatomy. And so for my patient, we actually decided to start some physical therapy. I did that for her for about 8 weeks or so. And, the snapping improved. It's a follow-up image where you can kind of see that snapping has improved. It's not so vigorous as before. But ultimately, if you compare both pictures, you can see the difference in that mechanism. And to me, that was pretty impressive. And it kind of shows the power of ultrasound that, hey, in this case, if you're torn between, is it there a degenerative component to your pain versus, just seeing if the patient would benefit from PT, that's important. So I want to, kind of take some time to talk about this paper from the AJR 2012 from Deslandis that really delves into the mechanism of the iliopsoas tendon snapping, this internal snapping hip syndrome that occurs. So here we see as that hip is flexed, and again, I'll click the picture for you, it's flexed, abducted, and externally rotated. That psoas tendon depicted by T laterally rolls over the iliac muscle depicted by M here. And that then becomes interposed, at the level of the suprapubic rami, that superior pubic ramus area. And so as I bring my hip back into the neutral position, that tendon then follows a reverse path, right? And so part of that muscle gets trapped between the tendon and the superior pubic ramus. And then ultimately you'll see that sudden snap that we tend to hear. Now, if you remember that pelvic rim acts as kind of an echo chamber. So the patient's going to say to you, hey, I really feel this audible snap. And sometimes for us, we have the patients reproduce it in clinic and, it's pretty impressive. So I think just understanding that and then translating it on a mechanism level, and this paper does a nice job of that. Be aware of, the so-called, bifid iliopsoas tendon. Sometimes you'll have that tendon being split where the medial head split in both a medial and a lateral head, and understanding is the relationship between that medial head moving over that lateral head while you're bringing the patient into flexion, abduction, and external rotation. And then that medial head snaps over while being trapped in the medial fibers of the iliacus. And then once you rotate back, it then snaps back over the lateral head. You get that loud snap. In fact, sometimes you can get a second snapping against the pubic bone. So this is the report I generated for my case. Be sure that you tell, hey, this patient had a hip pain with a snapping sensation. The location is anterior, laterality is right. I used both probes, a combination of linear and curvilinear probes. I did a focused anterior hip protocol using dynamic maneuvers from Faber to neutral, adduction, and internal rotation. Really, we spoke about that subtle difference, knowing that, okay, is this joint capsular distension because I've internally rotated that joint, or is it a true joint effusion? In our case, it wasn't a joint effusion, it was just really capsular distension. But then this is where the rubber meets the road, where you see the medial fibers of the iliacus interposed with the psoas tendon and that abrupt release. Consequently, we took a deep look. We saw that there was no bursitis. The rectus femoris tendon was intact. And that labrum, right? We visualized the labrum because we did have some degenerative changes, but interestingly enough, she had no labral tears or no paralabral cysts with no joint effusion. So overall, I told the patient she had internal snapping hip syndrome. We mentioned that the labral stuff may be degenerative in nature without a discrete tear, but we didn't have any bursitis there. And so what I want you to take from this case is really, one, understanding that when you're examining the hip, you can look anteriorly, medial, lateral, and posterior. But in this day and age, when you have 15 to 20 minutes with a patient, it's important to be really succinct and organized and allow your exam, to match the patient presentation. And that's why I focused on the anterior hip. The dynamic component becomes valuable here because now we're able to use that snapping mechanism and to our advantage by capturing it under ultrasound. MRI wasn't able to reveal that. In fact, MRI, if you went with that alone, would probably lead you down the diagnostic injection pathway, and you may have done an unnecessary procedure for the patient. So in this case, we saved the patient a procedure. And you may have some labral pathology, may not always be the driver, the primary driver of your pain, but again, the ultrasound helped us tease that out, especially when you have middle-aged athletes who have some underlying degenerative pathology. And more, especially here in South Florida, people are active. And so you want to be able to tease out those nuances that, okay, there's pathology there, but it's not necessarily the driver. And then understanding that variants exist, right? So you may be looking at a bifid tendon, a paralabral cyst impingement, maybe a post-surgical nature that's driving this pain. But really knowing which probe to use to analyze your pathology is critical. In my case, I use both the linear and the curvilinear. And this patient benefited from rehab. We did a lot of hip flexor glute core strengthening work. Obviously, we wrote an exercise prescription for that in conjunction with my sports physical therapist and my athletic trainers. But ultimately, we're able to, save this patient an injection. But if she wasn't improving, that's probably a conversation we would have had. But again, we're able to, lead with rehab and non-operative management. So the big picture here is where we can use the ultrasound to clarify the diagnosis in an athlete where, she had Paget's disease and osteopenia. And we kind of supported the findings of the MRI. We weren't overly reliant on that. And, it forces us to have this evidence-based care to our approach. So these are some of my colleagues here at the university. This is obviously my crew. And it's my references, and I really appreciate your time.
All right. Well, thank you so much, Stephen, for that comprehensive presentation and obviously demonstrating the high utility and valuable nature of using ultrasound, especially for these dynamic conditions. So just a few comments I was going to make, obviously, with this being a dynamic pathology, you had alluded to kind of the movement that you need to do to typically elicit this iliopsoas snapping, which is going to be that flexion, abduction, and then external rotation. And then it's usually going into that extension movement that the folks will feel that snapping. I think most of the time you can get it with the patients when they're supine, and then obviously be able to capture that on the ultrasound. But obviously, sometimes you do have to be creative, with these patients. You can have them standing or do the movement, that really creates it for them. So obviously, working with the patient, just kind of knowing what's recreating their hip snapping. And the one thing I would say for typically trying to capture that is typically then trying to increase the depth of the image, at that point, just because as you're going through that snapping movement, sometimes it can be a little bit deeper as they go into that hip flexion
Exactly.
component of it to truly be able to kind of capture it. So just a little tip if you're having difficulty seeing it. It is interesting that I think for the majority of these folks that end up having iliopsoas snapping, that's the main pathology that you see. I typically don't see a
Yes.
lot of patients that have concurrent tendon tears, or
Yes.
even tendinosis, or even
Mhm.
bursitis. So at least in one instance, I think you can provide some reassurance to the patient that yes, this is happening, this is creating your symptoms, but at least reassuringly, from that standpoint, it does seem, and I'm open to other people's experience as well too, but majority of these patients don't end up having significant pathology in the iliopsoas tendon itself. And then the last comment I was going to make is just as far as the pathology and patients that you'll see this in. Obviously, you had mentioned younger age groups, especially
Yep.
dancers, those with connective tissue disorders, especially something like Ehlers-Danlos.
Yep.
But can obviously see it in the patients like you had mentioned as they're getting older, especially if they have joint pathology. I think really the last group that I would mention is just those that have actually had hip replacements, as well too. That of course you can get snapping, related after an arthroplasty related to the iliopsoas tendon, or even within the components of that hip replacement too. So something to add, just if you are seeing that older age group. So those are just some of the comments that I wanted to make, but open it up for any other questions that anyone has.
Happy to take some questions on the case. Was an interesting case in that regard, kind of deviated from what we typically see. So I'm glad I was able to share it with you guys today. Thank you for the platform.
Hey, Stephen, this is Brennan Betcher. That was very interesting. I think my experience mirrors, both of yours, and that these are certainly challenging sometimes to really identify. And so, a couple of tricks that we employ here are: I always ask the patient, like, what exact mechanism do you find gives you the snapping? And I try and recreate that. So typically, you bring them into some flexion, external rotation, abduction sort of position, and then you and bring them back to neutral and back down. Sometimes allowing them to manually lower their leg helps, because that muscle contraction makes the snap a lot more forceful. So in people who have snapping, but then like you can't passively recreate it, I'll bring them into the right position. Then I'll ask them to very slowly lower their leg. And for some people, that is really helpful. I'd say usually we don't have to stand people up and have them get into those positions standing. It's also a little bit challenging to maintain kind of patient modesty when you're doing that.
Yes.
And so there are some like special, I'll say, like garments that are designed that have like a really high waist that you can use for these sorts of examinations to really like give patients their privacy. And so that's another portion just to keep in mind with these exams. And then the third thing is, the morphology of the iliacus and psoas and how they come together is really quite variable. And usually, my experience is similar to what you had there, where the muscle slides in between the tendon and the acetabulum, and then as it goes back into extension, that tendon drops down and essentially, traps the muscle, and then it snaps forcibly out of there. But people can have tendons that essentially snap back and forth on one another. So you can have multiple tendinous slips that can do this. And then you also, one other muscle that we don't really think about in the front of the hip, but is in this area that, can contribute, is the iliocapsularis muscle
Yes.
that's adjacent to the, right off the AIIS and under the rectus. It's also present. And so just trying to note, like, what the problem is. In reality, if someone needs surgery for this, they generally don't do anything to the muscle. They release, that they do a partial tenotomy or release a tendon. And so it probably doesn't matter all that much what muscle is snapping, but just especially for the trainees who are watching this, just noting that there is another muscle down deep in the front of the hip that acts to tension the hip capsule and hip flexion. So those are kind of the only things I had to add on the front. But yeah, these are always kind of satisfying cases to go through.
That was very satisfying. I think the patient walked away, feeling that she was able to avoid, going down this diagnostic injection pathway where, while it's useful, just as an active individual, I previously taken care of her knees and injected her knees. So she was really at her wits' end with needles. So I was happy to be able to navigate and use the ultrasound to help in this case here.
All right. Well, thank you, Brennan, for those additional comments. I'm not seeing any other questions or anything coming up in the chat. So I think that will conclude today's presentation. So thank you again for this. Really appreciate it.
All right, guys. Thank you again for the platform. Have a nice day.